provider in the state. And then we've also done a series of webinars over the last several years. And so we have covered topics looking at perinatal mental health as a public health concern. We've looked at dads' perinatal mental health. We've done some really community-specific webinars, so looking at Native women's experiences with perinatal mental health and Latinx women's experience with perinatal mental health. We are doing it. There's an upcoming webinar, for instance, that's looking at cannabis use in the perinatal period. So we are looking at a wide range of webinars around, common issues in the perinatal period that providers don't always get a lot of access to. There's not a lot of training programs in perinatal mental health. There's since COVID, a few more offerings that are, online. But before that, they're very difficult to access, especially for Washington state providers. So that's kind of a big part of the work. The second part of the work is an opportunity for communities to dive deeper in terms of looking at what's happening in terms of access to care, specifically within, their community. And a community could be defined as a geographic community, a city, or a county. It could be defined as a community based on a shared experience. So this year we're working with the Northwest Center, and we're looking at hospital homes, so families that have had experiences in the NICU. It could also be a racial or an ethnic group that is looking around perinatal mental health experiences, for instance, for a community, such as Black or African American families. So a community can be defined in a lot of different ways. And then the goal, right, of this community-based work is to increase community capacity in a couple of different ways, and I'm going to talk about that, and then establish easy pathways for families to access care. The last, that green triangle at the bottom of your screen is not exactly part of this project. So we know that every community needs high quality training and high quality access to specifically perinatal mental health care, right? So clinicians and mental health providers who have training in perinatal mental health. This project is really looking at, trying to support communities outside of the community mental health or not community mental health, but outside of the mental health range. We know that mental health capacity is very limited, right? And so one of the goals of this project was to think, how can we support families, right? Not just by sending them to the same resource that's already sort of overtaxed and doesn't have enough, right, capacity to serve the families. And I'm going to talk a little bit about the ways that we're doing that to actually increase access to care. My co-presenters are texting me. Hold on one second. I'm actually going to stop my share very quickly. I need to make sure that they get in, and they're having a hard time for some reason. There they are. Okay. I was just trying to respond to your text, Allison. I see that you're here now. I'm going to keep going, and then I'll introduce you when we start the Whatcom section.
Okay. Becky and I were clicking on the wrong link, so we were off in cyberspace, patiently waiting. Thank you.
Sounds about right, right? That's the current state of affairs, I think, for most of us these days. Okay, pulling up my slides, and I'm going to start. So the overall goals of the Perinatal Mental Health Initiative is to increase capacities within communities to be able to respond to the perinatal mental health needs, again, of their community, right? So there's a lot of room in this project for communities to come together, identify the gaps in care, identify the communities that most need to be served, and think through sort of how they might get those communities served. So, we're not sort of coming in and sort of saying kind of what needs to happen in terms of supporting parents. Specifically, we provide a lot of technical assistance. We provide perinatal mental health expertise around thinking about systems and capacity and community building, but each community has really a lot of direction in terms of sort of exactly what they would like to do in terms of meeting the needs of the parents. And then for the parents, we want there to be easy pathways, right? We want parents to be able to find the care that they need, right, without lots of barriers. And there's several ways that we're working on this. So this is sort of a broad, overview of our community capacity building approach, right? So we're looking at a couple of levels of change. It's a very unique program where we're thinking about kind of all of these levels at the same time and trying to evaluate them, which I'm going to talk a little bit more about. But looking at sort of the parent level, we really want them, right, to have access to care when they need it, right? So we know that parents need support, right, in the moment. They, direct service is a very important part of, perinatal mental health capacity building in general. And we also know that parents, need providers who look like them, who speak their language, who understand their culture. And so as best as possible, we often try to provide training to folks that are from the communities that are going to be serving. And so we're able to provide culturally matched care. And there's a couple of different options for direct service. Communities can start a perinatal mental health support group, or they can do a one-on-one model. And this works for, to give communities, again, a little bit of choice in serving their community, knowing that, that they know their communities best. And that a group model may not work, perhaps a rural community, perhaps a community that's going to experience a lot of barriers, right, such as transportation or childcare, whatever is happening for each individual community. And then the parent also, in general, not just with the one-on-one direct service or the support group, but in all of the providers that are working on this project together and are getting access to training, they're going to have access to providers that are better trained, right, and have more awareness around perinatal mental health, thereby increasing, right, if they're, in a home visiting program, or if they're going to a support group, or perhaps, at their pediatrics office. Again, if we're training those providers in supporting parents experiencing perinatal mental health complications, those parents are going to be better overall. For the providers in the community, they're going to have access to training and consultation and perinatal mental health sort of expertise. And so, some of the things that we provide training on is the spectrum of perinatal mental health, appropriate and effective screening, appropriate and effective referrals, but also, how to implement, a screening program, or how to, do something on a systematic or a programmatic level, and not just that one-to-one, kind of interaction with the parents. And then the community as a whole, right, the system level changes that we're looking for is overall, right, professional awareness and training, increase in sort of, resource and referral protocols specific to perinatal mental health care, right? So how do you get your client into the care that they need? Perhaps triage protocols, crisis protocols, if the hospital folks are participating in this project, more direct service referral options. We're looking for an increase in perinatal mental health screening, and overall public health awareness. And so those are kind of the things that we're looking for in this project. So this is pretty ambitious. We're trying to do a lot here. And this is the approach. This is kind of the phased approach, just to give you a bit of a visualization. So the first phase is this task force creation and community building. The second phase is providing training to the community, and I'll tell you a little bit more about what training we're providing. The third is, right, once folks are trained, right, both community providers in sort of the general spectrum of perinatal mental health, but also the support group leaders, right, or the folks that are providing the one-on-one parent support, they'll be trained in the model too. So then we're ready to start developing new services. I put perinatal mental health treatment here in quotations, because again, this exact funding is not trying to specifically train perinatal mental health providers or clinicians. But as you'll hear from the Whatcom County task force, is they have done a beautiful job of blending some funding to really provide training for mental health providers in their county, and they're going to talk a little bit more about that. So that's certainly, several of the counties that we've worked with have used a blended funding approach to do more, using the task force sort of as their backbone, sort of organizing the decision makers and the folks that are deciding sort of what happens and sort of when, and doing some of that work. So as the new services are ready, right, then, right, we are now kind of moving towards kind of referral, screening for parents, because we now have services to refer them into, right? So we don't want to jump to screening, for instance, and we don't want to jump, to identifying folks in the community when we don't have some services in place, right? Because we're going to create kind of the same situation that I think a lot of us are in the communities that we're serving, which is, where do we send the parents, right? There's a huge capacity issue. And so again, thinking about the support groups and the one-on-one parent support, these are services that are outside of the formal mental health sort of field, right, or the mental health world. And they're intended to provide sort of additions for, as a resource for families in each of the communities, and for the providers to have a place to send parents who are struggling. Again, so thinking about after those services are in place in phase 3 and in phase 4, now we can start to kind of roll out, some of those screening programs, the referral pathways between programs, between hospitals and nonprofits and sort of the different organizations that might be working together to bring these direct services to the community. And then phase 5, right, that's when, we can actually make a concerted effort to doing more public awareness on the community level, so family levels, for instance. And it could be, sort of formal or informal, right? So there's a lot of ways that we could potentially be sort of, increasing, public awareness. So it can be within the clients that we're serving in our programs. It could be, the resource and referral guide, which I'm going to talk a little bit more about as one of the grant activities, really sending that out widely. It could be outreaching to the local pediatric offices, OB offices, things like that about the new resources available in the community. So the team, the approach, there's sort of, 4 kind of, different parts of the team. So there's Perinatal Support Washington, which we provide the perinatal mental health, technical assistance, and expertise. And so we're sitting in on the task forces. We're arranging for the trainers and the perinatal mental health trainings. DCYF is the funders, they're the contract holders, they're our thought partners, and really thinking about this work and getting it out into the community. There's the evaluation consultants, which are contracted through DCYF, which are helping us to evaluate sort of all of the work that we're doing, which I'm going to tell you a little bit more about some of our outcomes. And then, of course, there's the local organization that applied for the funding, and then the community as a whole. And all of these team members are working together throughout the project. So as I was saying before, it's a really unique approach, right? It's focusing on, both direct service, which we know that parents need a place to turn, right, when they're struggling, and also the systems. If we're only doing one or the other, right, then parents aren't getting the care that they need when they need it, right? Or, we're not sort of, kind of figuring out how we're going to better support parents overall. That one direct service, that support group provider, that mental health provider, that one-on-one parent support cannot do all that work alone, right? That's not the only thing we need. We need to be thinking about, right, how are we, coming together and breaking down a lot of the barriers and inequities that parents are experiencing around access to care, right? And so that's kind of the work of the task force. The work of the task force is to come together to bring together sort of like multi-sector, providers, folks from kind of different parts. If it's a community, a geographic community like a county, which a lot of the work that we have done has been county-based, and so folks that are coming to the task force are actually representing smaller communities, right, within that larger, county community. And so again, thinking about who's at the table, who's not at the table, whose voice is being heard, what communities, again, within that geographic community are experiencing the highest gaps in care, and how are we coming together to serve those, and thinking through who is the most appropriate direct service provider for that. Who is, the folks that we need to make sure are getting trained, so that parents are getting the care that they need. So a little bit more specifically about the task force, that's sort of the backbone of the community capacity building program. The task force brings together those multi-sector providers. There's also an important focus. We really do want parents at the table, parents with lived experience. I think in the perinatal mental health field or the perinatal mental health world, we often see that there can be both too, right? Providers who are also people with lived experience. And we find that with lots of our trainings and lots of the work that we're doing, that there's lots of overlaps, and we end up when we're covering the training, the perinatal mental health training component, having lots of kind of emotional response to the work, right? Because this isn't about clients, this is about people and communities and parents, of which we all are. And so it's very personal work. The task force also identify and plans for, the task force activities, right? So there's some things that are kind of set by the grant, but there's lots of room for each individual task force to, do the things that they see are needed to do. Set goals and track progress. Also track unintended outcomes, things like, someone who attends the perinatal mental health training and then goes back to their program and implements a screening, practice or a screening protocol, or uses the resource and referral guide, which I'm going to talk a little bit more about, to develop something at their site. So there's, we've been really excited to see some of the things that have grown out of it that have not been formal tasks that the task force has sort of set out to do. And then create inter-program and inter-system collaboration. So here's the grant activities. I'm not going to go through sort of everything in particular. I've kind of highlighted some of these. Each community does have a task force. They do get access to a community-specific perinatal mental health training, which is actually a really valuable time to get 50 providers all from the same community together talking about perinatal mental health in a focused way. It just doesn't happen very much, and so there's often a very rich conversation that happens there. Again, there's that direct service component. And then we haven't talked about this in particular, but there's another grant activity that we've asked each of the grantees to complete, which is to create a very specific resource and referral guide for whatever community they're serving. So again, if it's a county, then it'll be a county-wide resource and referral guide that's only perinatal mental health resources, right? So it doesn't have things like the food bank on it or, diaper access or things like that, but it has, any of the mom and baby groups or parent baby groups. It has any of the specific, perinatal mental health support groups, the mental health referrals in the county, things like that. So this is some of our preliminary data collection that I was telling you about. We did a community capacity survey. We then also looked at the direct service outcomes, so the parent level outcomes, and then we looked at the provider level outcomes. And this is from our first year of the grant, which was 2019. So we had 7 funded communities. We trained a lot of providers in the one-day perinatal mental health trainings. We trained a lot of support group leaders. Again, you can see some of the breakdown there. And we engaged maternal and child health care providers in the local task forces. Our original survey that we sent out to everyone in that first year who participated in their local task forces. So we had about 150 folks who participated in task forces. We had about 105 respond to the survey. And in general, right, this is what they are telling us that the barriers are in their communities. None of these are things that every single person in this call doesn't know. But when you sort of see it in black and white, right, you have the evidence to say, right, this is what communities are experiencing, and this is what we need to address. And so again, none of these are surprising. We all know these are there. In particular, that there's not enough providers of color. There's not enough providers who speak languages that the clients need. There's not enough providers that look like the clients that they're serving. And oftentimes clients don't get the care that they need because of that. In general, we wanted to get a sense of, not just sort of the barriers that families or providers were experiencing, but what their perceptions were of the resources. And so you can see I've highlighted here, there's lots of text on this slide, but in general, right, there was a pretty low, rate in terms of thinking about, knowledge. So for instance, somewhat knowledgeable, about perinatal mental health. The second one is looking at, we're asking them to identify just community, people in their community, so not necessarily providers, right? So, individuals, they could be childcare providers or, someone who is not necessarily a maternal and child health care provider. And they identified that they had somewhat knowledge of perinatal mental health and the resources. When they were asked what they felt like the families in their communities knew about perinatal mental health, they said, a little bit or somewhat they knew of a place to turn for information and support. And then here are the last two, which these are kind of the big ones. They believe that there were not at all, right, or a little bit of treatment options available for families. And that the treatment options were not at all or just a little bit accessible, right? So really back to that accessibility issue, that even for the communities that had some resources, they weren't accessible for all. The Strengthening Families Washington team uses the 5 protective factors. So these might look familiar to you. And our support group outcomes, looked pretty good. So we saw improved parental resilience, improved confidence with being a parent, improved understanding about self and being a parent, improved connections with their children, and improved connections with other parents and decreased feelings of isolation. So pretty good outcomes with that. These are the percentage of the folks that were in the support groups that were being served in that year, the demographics. And then for the providers, so these are the folks that attended the one-day perinatal mental health trainings in each of those 7 counties. So this is the breakdown of who we trained. And then here's some of what they reported in terms of their overall sort of change after attending the one-day training. So pretty high rates of having more confidence, having more knowledge, being able to identify risk factors, knowing how and where to refer families. One of the things that we do at the perinatal mental health training is we have a section of the day that's really talking about sort of community resources, and the resource and referral guide that I mentioned, the goal is to have that done by the time we have the one-day training so that providers can have it, they can talk about it, and sort of walk away with a really concrete resource now that they are trained to identify and screen for perinatal mental health complications. They have that correlating sort of resource and referral pathway to then send the clients that they're serving. So I'd like to introduce Allison Williams and Becky Shays. They are longtime partners and friends and colleagues up in Whatcom County, and they're going to talk to you a little bit about some of the work that they've done with their task force.
Great. I'm Allison Williams. I'm going to start us out. I hope everyone can hear me okay. Mia, you're going to advance the slides for us. You can go ahead to the next slide. So for those who don't know where Whatcom County is, we're way up in the northwest corner of the state. We have a population of about 228,000 people, and about 40% lives in the main city of Bellingham, and the rest live in much more rural areas. About 12% of our population speak a language other than English. And like many places, well, not just in Washington, but across the country, there are a number of people that are burdened by housing costs. So about 50% or more of renters are spending more than 30% of their income on housing. And I just wanted to give a backdrop of data about Whatcom County. and a setup for that. I work for the Whatcom County Health Department, and in 2017, the health department conducted an assessment of child and family health, and that came out of findings from our community health assessment and a prioritization that focused on children and families. And what we found is some of the key quantitative data indicated some indicators that would show an increased risk for people to develop perinatal mood disorders, such as having a lower income or being non-white. And so you go to the next slide, Mia. I'll just quickly kind of show you some of the information that we got out of our child and family assessment. In our younger population, children under 5 in Whatcom County are much more diverse than the total population, and that's true across the U.S. The percentage of children under 5 in Whatcom County that identify as Latinx is more than double that of the total population. Currently, about 44% of Whatcom County children under 5 are living below the 200% of the federal poverty level. And these folks, these small children, are our future parents and caregivers. You can go to the next slide, Mia. The percentage of all births to lower income women in Whatcom County has increased slightly over the last 10 years from about 47% up to 52%. This data that you're seeing is a little bit old. It is pulled from that child and family assessment that we did in 2017. We also know that untreated perinatal mood disorders can impact kids. And so we looked at kindergarten readiness for Whatcom County students. And when compared across the state, Whatcom County students are slightly, you can go to the next slide, Mia, are slightly less socially, emotionally ready for kindergarten, particularly lower income students. And the next slide, Mia, too, just shows our rate of child abuse and neglect in Whatcom County, which has been consistently higher than Washington State for well over a decade. That's on the next slide. No, I'm not sure if there's a little. And Mia, can you go to the next slide, please?
Slide, can you not see that right now?
Oh, I guess what I see is just social emotional readiness. Oh, there we go.
Okay, it might just be a lag.
That may be a lag in my internet. Yeah. And you can, so we also gathered some qualitative data for this assessment through focus groups, and we with community partners hosted several World Cafe discussions. And we also convened 72 stakeholders over a period of 2.5 days for an action planning meeting that grew into a community collaborative called Generations Forward that focused on what children and families need to thrive in Whatcom County. So there were a quarter of those stakeholders were parents with lived experience. So we really heard a lot of what families saying what they need through those focus groups, those cafes, and that convening. And I don't think anything on this slide will be a surprise to anybody who's on this call. It's similar to what Mia was saying earlier. Parents they want support from other adults. They want support from through providers that look like them, that speak their language, understand their culture. They want centralized, coordinated support system. They want that system to be flexible. They need quality, affordable childcare, family-friendly spaces. So none of this is probably new to anybody here. So you can go on to the next slide then too. So what prompted us to form a task force? As I've said, in Whatcom County, over a period of years, leaders have been, I would say over the last 5 years specifically, really focused on young children and families, recognizing that investing in our youngest children from the start is going to be the most effective approach to improving health and reducing disparities and advancing health equity. And One identified need that we heard strongly from both families and providers is increasing our community capacity to support families during the perinatal period, especially for families that were experiencing poor mental health, knowing that ensuring that health and well-being of the next generation is tied tightly to the health and well-being of this generation of parents. So in addition to the qualitative data that we gathered from focus groups, we also, it revealed barriers to accessing support services. And these barriers, whether they were language and cultural differences or lack of transportation, lack of childcare, a lack of a sense of belonging, are creating some social isolation in our communities and limiting access to social services, including peer support. And in Whatcom County specifically, some of those barriers are geographic because we have very rural parts of our county, and some of those are language barriers or population-based, and some of those by geography. We also use the Strengthening Families framework and looking at its 5 protective factors that support healthy development. We focused on social connections, knowing that high levels of support for both mothers and fathers is associated with positive parental mood and well-being, parenting satisfaction and competence, and lower levels of anxiety and depression. And the time was just ripe through different community coalitions that were working focused on young children and families, and different organizations and entities in Whatcom County, that it seemed ripe to form a task force that could start developing prioritized areas for action and strategies to go along with those actions. So I'm going to turn it over to Becky Shays for the rest of this presentation.
Thanks, Allison.
Yeah.
So you can go to the next slide, Mia. So
the Whatcom, great.
Yeah,
there.
Perfect. Yeah. So as Allison was saying, you know, it was, I love the term ripe. That's what it felt like when we all came together. There was a lot of energy. It was really the merging. So our task force, I guess, formally started in January of 2017. And it was sort of the marriage of 2 main groups. One was a small work group off of our First Steps Coalition, which is a countywide group that basically functions to coordinate services across different service. They don't necessarily coordinate them, but they work trying to de-silo some of the care. And towards the end of 2016, there had been some interest in creating a focus group around perinatal mental health. And at the same time, there was a small little group of direct service providers that included LMHC, myself, parent advocate, psychiatrist. And it just sort of almost was a beautiful illustration of what Mia pointed out, which was this unique blend of both sort of the theory and the importance of public health in the setting of perinatal mental health within the public health setting. And I just realized, oh, they're now they're back. Okay, hopefully you all could see the slides. And I think it was that synergy that came off of folks who were sort of down in the trenches, so to speak, seeing parents working one-on-one, and also the interest and having the ability to work with public health. So we can go to the next slide. If Mia's there. Now I don't even see, oh, there we go. And what was really key to our success, honestly, was being able to partner with public health. And they literally, again, they provided this backbone of support. Sort of, they really created a home for us, quite literally. They provided meeting space. They provided really critical FTE, but they also helped create the bigger context that those of us providing direct service can sometimes miss. We can get stuck in the weeds of just dealing with patients and referrals and providing the care. and often don't have time to get into that larger policy side of things and really work to make change. So having access to public health and their, when we were convening our table, we had, at our biggest days, we had upwards of 20 to 25 people sitting around our table, from the FQHCs in our community to the private practice family physician offices to our OB, and I think it was really just the OB side of our hospital-based OB group. Lots of other different service providers within housing, domestic violence, all these different intersections of places where women may interact during their childbearing years. And we really can credit that to the role of public health and the Whatcom Health Department. And that allowed us to just start at such a high level and really get moving on things. You can go to the next slide, Mia. So we just laid out here some of our initial goals of our task force work. We did spend a large chunk of our first meetings, which we would meet once a month for 90 minutes. And, a lot of it was just sort of trying to figure out, where's our common ground? Where are we all trying to go? Just like so many of the slides, we could all say all those things. If there's not enough access, even if there is access, how do they navigate it? Half the providers are full. How do we keep it updated? There's not enough language. There's so many different things. And so this is sort of what grounded us in our work and let us start to move forward, which we just committed to increasing community awareness, increasing capacity, and trying to develop some more community support systems. And then we really wanted to create a resource list. And that seemed to want to be first. Mia, you can go to the next slide. And because we realized that everybody was working off of something different. And then we went to create our resource list, and we realized that we didn't really have that much to put on it. And so we sort of took a step back from that, and we started this process of first surveying providers, and we use the term provider really globally here. So we sent it just far and wide through all of our networks, everybody in the task force. We ended up getting 117 responses, which we were pretty happy about, because we were sort of an unknown, very new entity at that point. And what we learned was really mirrored what Mia
You froze.
Becky, I think we might have lost you. Allison, do you want to jump in here until Becky comes back?
Sure. Yeah. Let me pick up our notes section. Oops. Here. So yeah, as Becky was saying, we had really good response. What we did learn that many of the, oops. Yeah, I just got a text message from her saying that she got kicked off and she'll try to get back on. That we had many providers that had not had very much training and were interested in a lot more training, and not a significant number of providers that were using a validated screening tool. So we can go on to the next slide. So the grant that we had allowed us to host two, well, over time, one in 2018 and one in 2019. We did community-wide trainings, and primarily these were mental health providers, but more we also had folks attend through that were part of serving children with special health care needs and early learning community. And I think we had about 100 attendees for the first training, which was very, very broad. And then the second year was a much more focused training. We're also able to support a clinical training and consultation group for mental health providers that one of our task force members hosted. We were able to expand some peer support groups, and some of that expanding peer support groups were specifically training bilingual, bicultural peer support group leaders based on the qualitative data and the quantitative data we had from the child and family assessment of a need for groups specifically for Spanish-speaking mothers. And then we also did circle back to our very first objective, which was creating a resource list and a communication tool. And that took us probably nearly a year, because we were, as Becky was saying, we really needed to develop some pieces to actually be on there. We needed to train more providers who felt like they had the skill to take on specific treatment for women experiencing perinatal health mood disorders. Can go on to the next slide. Let's see. I think, okay, this is sorry, there's a little lag with my internet. So I think that Mia referred to this earlier. One of the things that we were able to do is blend some funding for our task force. So we relied on a few different sort of funding sources. One was the grant from DCYF that really focused on building out the peer support directly for families and training those peer support leaders. We were also able to apply and use our local Whatcom County Behavioral Health Tax Fund dollars, which is a 0.1% that goes specifically for behavioral health funding. And as I had mentioned earlier, our county council has had a specific focus on children and families, which allowed us then to apply for using these county funds to expand provider training. So the clinical support training that I referred to, the 10-month-long specific clinical consultation support for mental health providers, that support was paid for through the Behavioral Health Tax Fund dollars. And then public health committed some of my FTE to provide backbone support. Some of the task force members also were part of organizations that they were able to attend as part of their FTE. And then we just had countless volunteer hours through moving this work forward as part of the task force as well. And can go on to the next slide. And that might be the last one. No, what are we working on now? Well, we had a big pause, as many communities have, because of the pandemic. Of course, that does not mean that the work is not even more critically important. But we have had, because the one downside of partnering with public health is when a pandemic hits, you lose some of your public health support. And we had to step away from being able to provide that backbone support, and now we're just now being able to come back to provide more backbone support. But so we're working on expanding the current peer support groups. Some of the peer support groups that we expanded had to contract because they didn't feel like they had a safe way to meet, and the population they were serving, it didn't really like the virtual meeting methods. So some of those have gone into rest for a moment until we can figure out what works for those groups. We're working on more on a policy advocacy end. We had just started before the pandemic hit. A subgroup of our task force had developed a 1-hour CME specifically for health primary care providers, so pediatricians and family practice docs, OBs, and they had just started to take that on the road and had trained, provided training for about 30 providers. And so looking to restart that. And then because we've had this pause, just trying to reimagine what should our structure be? How do we align with, there are several other community collaboratives going on that we want to align our efforts with and just strengthen and diversify our task force. And then I think this is probably true across the state and other county levels, is just developing more meaningful local level data around perinatal mental health. And that's been a long time wish of ours as well. I don't know if Becky is back on. I can't. Yes.
I am. Thanks, Allison.
Okay. I'm sorry. I'm not sure what your note, if I touched on all your notes. So
I'm sure you did a great job. I'm so sorry. My internet just like totally dropped. So thanks.
Do you have anything to add?
I don't know what you said because I wasn't on. I literally just got back on. I'm sure everything you said was terrific.
Thank you both for sharing your experiences. So just in the last few minutes, there is the opportunity for communities to apply for the DCYF funding, and also to just think about how you would want to do this work even outside of that funding. I'm going to give you just a little bit of information about the upcoming, sort of thinking about it if you were sort of interested. So we are seeking new communities. I'll tell you a little bit more about the grant coming up. But some of the unique sort of parts of this project is right that the grantees, right, the funded organization needs to be able to think on all three of those levels, right, parents, providers, and community. And those are different sets of skills. And so we're really encouraging folks to think about partnering with local organizations and thinking about sort of who might be sort of ideally situated to run the task force, right? You heard a little bit about Whatcom's process with thinking about sort of how the different parts of the team came together, to really create a strong, functioning task force. And so, if folks here are thinking about potentially applying, I encourage folks to think about, who is ideally situated to do that community level work. To connect with, the other maternal and child health leaders and programs and providers in whatever sort of, however you're going to identify community. And also, right, there's that piece of who is uniquely situated to provide the direct service capacity. So the DCYF folks have really created a lot of provisions in the contract to be able to subcontract, right? So like the same person or the same organization doesn't have to do it all, right? You can think about who might be the task force leader, who might be the direct service provider, and thinking about some of those kind of different roles. Just a little bit about the upcoming grant cycle. So the application will open in March-ish, 2021. The funding is yearly. There might be some ongoing potential to have funding. Most of the counties that we're working with, or the communities that we're working with, I should say, have had multi-year funding. And again, really thinking about community is defined by you all, right? About who you are sort of uniquely writing this the contract or the application for. So it could be a racial and ethnic group. It could certainly be a geographic location like a city or a county, or it could be by shared experience, right? So for instance, the example of, one of the grantees this year is the Northwest Center, and their sort of shared experiences is supporting families in the NICU. And they're doing a really great job bringing together, a lot of the big providers and the organizations that are serving families, who are transitioning out of the NICU, and doing some exciting work around incorporating perinatal mental health into the ESIT teams across the state. So that's really exciting work. The announcement, the open application will go out, sometime soon. So I encourage you all to get on to the Strengthening Families Washington newsletter list, and also the PS Washington. We'll send it out widely. We really want to recruit some new counties and some new communities to work with this year. So with 5 minutes to spare, I'm going to stop the share so I can see some folks, and happy to answer any questions that you all have. And if anyone has questions for Becky and Allison, you're welcome to ask those as well.
At the beginning, you mentioned 10 counties are active or have active task force or funding. I'm not sure, but could you say which counties those are?
So the current funded counties are Yakima, Cowlitz, Pierce, Clallam County, and then the Northwest Center, which is that NICU, hospital home. So they're not all counties. Other counties that we have worked with over the course of this grant: Snohomish, Skagit, Grace Harbor County are some counties that we had also worked with at one point or another.
Thank you.
I'm happy to send the slide deck out to anyone who registered, and it'll probably also be available on the website. This recording will also be up on the website in a week or two, and anyone who hasn't registered is welcome to watch it. You don't need to have registered to see it. Other questions or comments from folks? Yes, it is deeply needed in the eastern side of the state. And one of the reasons why we're hosting this webinar today, we would really love to get the word out to organizations. Yakima County is the only county that has received funding. However, we have done some very targeted trainings on the east side of the state because of the most of the funded counties or communities being on the west side. And so we've done more of our trainings on the east side, and also opened up, for instance, our support group training to counties on the east side, even if they weren't part of a funded community doing that very specific work. But when the announcement comes out, please share with communities on the east side of the state. And PS Washington has been doing some really targeted outreach as well, and setting some meetings up with folks in different parts of the state to make sure that they know about this opportunity. Great.
One thing I wanted to mention is when I registered to attend today, there was an option to be on like the directory of services or something like that. But the questions to get registered for that were very specific to like individuals, like asking a license number and like your if you're infant mental health certified. And so I'm an administrator at an agency, and I have infant mental health certified people that work for me, but I don't have all that information at hand to have been able to fill that out. And so I was just thinking somehow having a directory that includes, more an agency level rather than an individual level provider information would be good.
Mm-hmm. Yeah, we're happy to list an agency. However, we do actually have training requirements to be listed on our website, right? So in order to be on the directory, the individual providers need to have specific training in perinatal mental health. And so, why don't you email me? We'd be certainly happy to list the agency, right, as sort of like the listing, and then we could list in the, the body of the listing, the specific therapists that do meet the requirements. But we would need some way to identify which therapists those were and what their requirements were.
Sure.
We could talk about, a sort of a streamlined way of doing that. But we're happy to list agencies in general. But what we aren't sort of able to do is list agencies that don't have specialists on staff.
Sure. Okay. Thank you.
Christy, where are you coming from? What agency?
Institute for Family Development, and we have a PAC program in Pierce County. And so one of our home visitors has the infant mental health certification.
Mm-hmm. Wonderful. Yeah, be happy to talk about listing your agency. If you want to email me, I'd be happy to talk more with you about it.
Sounds good.
Thanks, Linda. Always good to see you. It's just about 4, or I guess I didn't get to see you. I got to see your name, but happy to, you're welcome to email me if anybody has any further questions. And if not, I hope you have a lovely rest of your day. Thank you all for coming today.